Chair of the AAP section on obesity and represents the AAP section on obesity's visiting professor program for this talk. And I think I've also read that she is a Walk with a Doc leader. She is speaking today on building a foundation for healthy, active living. So please help me welcome Dr. Muth. Thank you.
Thank you very much, Dr. Greenspan and Leanne. It's really my pleasure to be here today with you guys. I'm in San Diego, so not local to Vegas. I was supposed to be there in the spring before COVID happened to be able to do this talk, but I'm really grateful to everyone for making it happen through this remote setting. So I'm really looking forward to sharing with you some information on how to really build a healthy foundation for healthy, active living for our youngest patients. I'm here on behalf of the American Academy of Pediatrics National Section on Obesity, where I'm currently the chair, and this talk is supported by the CDC and the AAP Institute for Healthy Childhood Weight, who prepared it to be able to provide pediatricians with the latest and greatest on how we can help our youngest patients to be healthy. I also want to thank Dr. Jeff Yu, who was a chief resident at UNLV last year, who applied for this visiting professorship and made it possible for me to be able to be here today, as well as to your chapter and to your leadership for having me. I have no disclosures to share. So the things I'm going to highlight in probably about the next 45 minutes or so, and then we'll have about 15 minutes at the end to discuss a little bit and have some questions, are really some tips and things on early feeding practices for our youngest patients, 0 to 5, discussion of a little bit of the environment and how that impacts risk for childhood obesity and what we can do about it, discussion of some early relationships and the role that they play, some protective as well as risk factors for the early development of childhood obesity. What we should be doing as pediatricians. I'm a general pediatrician, as Dr. Greenspan mentioned, and I also run a healthy living clinic, which is based in primary care. So really seeing patients the same as you with our well checks and kind of the sick visits and all kinds of opportunities to impact them. And then come up with a few strategies that we can easily deploy given the limitations that we have in time and resources. So as many people are maybe aware already, of course, we have an epidemic of childhood obesity that's been kind of pretty persistent and difficult to impact significantly over the past several decades, really, whereas now about 17% of children who are aged 2 to 19 have obesity. And as we know, there is a higher prevalence of obesity in our most at-risk patients in minority and ethnic and racial groups and children who are living in poverty. And we know that obesity starts young, and young children already are impacted. We know that about 1 in 3 children have obesity or are at high risk for developing obesity before their 5th birthday. And we also know that obesity tends to track. So kids who have obesity when they're 5 are likely to have obesity when they're 12 and are likely to have obesity when they're adults. So we really need to or can make a huge difference by impacting our youngest patients and being able to identify risk factors for obesity early on, and also being able to identify patients when they're very young who already have obesity. And the smallest changes at those young ages can actually lead to the most significant differences. Whereas if we make that same small change when a child is older or teenager, it's much less likely to have as much of an impact. So in sum of kind of the rationale and the reason for this talk is that we know that the first 1,000 days are critical, and we need to really be thinking about that early on, our well checks from the very beginning about the nutrition, the environment, and the relationships that our patients are experiencing. This is so important because we know it's early childhood when children are developing their typical kind of eating, activity, and sleep patterns that are likely to stick with them as they get older, especially if there's no change made or intervention done. And it's also a unique window to really shape healthy habits because for a lot of reasons, but we know that parents, especially when their kids are the youngest, we're seeing them all the time. They tend to do more proactive work in helping their children, their babies, to be healthy and learning a lot about their development and what to expect. So we can really help with that strong foundation by kind of targeting nutrition early on, the relationships our patients have with their families and that bond early on, and then the environment in which they're growing up. So here's a long list of potentially modifiable factors that play a role in the early onset of obesity. I'll let you look through this bulleted list. We're going to explore some of these items a little bit more over the coming slides. But you can see, there's almost 20 things here that we can impact, or things that can be changed that can help our kids to be healthy and help to recognize early risk factors for obesity, and then intervening on some of these factors. If we notice that we have a child in for their 9-month well check and they already have a weight for length that's at the 99th percentile, well, we should address that. We should be looking at weight for length. We should be talking about that in a non-judgmental, positive, proactive way with the families. We can be talking about tummy time from the very beginning, well checks. And in fact, tummy time and that movement, gross motor development, these fundamental skills that babies learn can be really impactful in helping them to set the stage for activity early on. Of course, we talk about this a lot. There's talks in the CME about breastfeeding and the role that breastfeeding plays, not only in the protective impact of breastfeeding for our babies, but also in getting them the exposure to different tastes early on, even passes through the breast milk, even the amniotic fluid that helps kids be more likely to try foods as they're beginning solids. So there's really lots of things that we can intervene on, specific to the patient that we're seeing and to what the parents are telling us are their concerns or their challenges. And so as you kind of think about social determinants of health that we talk about a lot, and you think about this approach to impacting behaviors, there's the individual factors, but there's also family environmental factors. Well, it's the same with helping kids at the earliest ages to prevent obesity or to treat it early on. So we want to think about prenatal and perinatal risk factors. True, mostly we're seeing the kids, after they're born, but lots of the babies, their parents have other children, or we'll have meet and greet visits where we have expecting parents coming, and those may be an opportunity for us to impact the perinatal environment. And then of course, we're checking growth whenever we see our patients. We're talking about nutrition. Maybe we're talking about their home environment and their parenting strategies. Maybe we aren't. If we aren't, maybe that's an opportunity. And then just, our advocacy through the environmental factors and trying to positively impact our communities. So let's take this, let's dig a little deeper and take this kind of from a developmental perspective. So I'm going to talk about, remember, we're focusing really on these first 1,000 days, or even, negative 9 months to age 5, a little bit broader than 1,000 days. So we'll break it down with some things to think about in pregnancy, infancy, for toddlers, and then early childhood, all where we can focus, but also be specific and targeted in some of our recommendations or anticipatory guidance. So for pregnancy, we know that the right amount of weight gain, the ideal or the recommended IOM weight gain of about 25 to 35 pounds during the pregnancy is what's going to be most beneficial for the baby to be born at a healthy weight and to have less risk of obesity later on. Minimizing smoke exposure, monitoring for and assessing for gestational diabetes, and that kind of goes hand in hand for the most part with the appropriate weight gain. There used to be, which are very now outdated, recommendations of limited activity for pregnant women, but in fact, it's great for pregnant women to be very active and to continue the activity that they've been doing beforehand. And of course, if they're going more intense than what they were before, talking with their OB. Healthy, varied diet. So we know, general recommendations, eating lots of fruits and vegetables, minimizing processed foods, sugary drinks, things like that for pregnancy. But as I alluded to earlier, we also are starting to learn more about how the flavors and tastes can pass through the amniotic fluid. So it's really fascinating research, but we know that, moms who are eating more vegetables or bitter vegetables, spicy foods, for example, even allergenic foods during pregnancy, are likely to have babies that are going to be more accepting of those foods later on. So it's a great opportunity already to try to reduce some of that picky eating that comes around too, by having a varied diet in pregnancy. And then, being prepared for breastfeeding, to try to help optimize breastfeeding success, prenatal care, etc. All of these things we hope will help having a full-term healthy weight baby who will be ideally breastfed at least, some of the time. Some is better than none, ideally for exclusively for 6 months, as we know, but as much as a mom can do is fantastic. It's important and helpful for a mom to return to a healthy weight after pregnancy. And those positive health habits that she has are going to be impactful for her baby and for the child as they grow up, because we know that role modeling is going to be very important. And it's kind of one of those things that is very impactful and parents underestimate, but role modeling really works. And then, more and more, we're really trying to assess in the pediatric office for maternal depression, because we know that it poses risks, for the mom, of course, and we care a lot about the mom, and we know that it poses risks for the baby, obesity being one of them. So kind of screening for maternal depression and helping connect a mom with resources in the community. Okay, so baby's born. We're seeing our this baby for the newborn check. We're going to be seeing this baby many times over the first several years of life. What can we be talking about, or what should we be looking for during those visits to help that baby to be healthy in many ways? And one of those ways of be healthy, of gaining the right amount of weight during the early years and trying to decrease the risk for developing obesity as much as possible. We discussed already, breastfeeding. The research on the impact of breastfeeding on childhood obesity is evolving. It seems like it's mixed a little bit. So it's not to say that breastfeeding is going to make it very, very low risk that the child can develop obesity, but it does help to mitigate the risk, and it's also probably pretty helpful in using a baby's cues for hunger and fullness. We call responsive feeding, to be able to assess how much to feed the baby versus formula-fed babies or babies that are fed with a bottle. Parents tend to be a little bit more concerned with the amount of food, amount of formula, or even the breast milk that the baby is getting. And sometimes there's a little bit of risk of overfeeding, which could contribute to excess weight gain. Active motor play. So our developmental well checks, we're assessing the areas of development. We're assessing gross motor development, fine motor development. Let's really key into that gross motor development. If a baby's delayed, really addressing that and getting resources in place early on can make a huge difference, because that baby can then catch up with motor skills. And if they catch up with motor skills, then they're going to be more likely to be active as they get older. Whereas a baby that's got gross motor delays, you can imagine as they become a toddler who's delayed and then a school child who's delayed, they may like activity less because they aren't as good at it, and then it can kind of set off a cycle. So really starting from the early visits, the newborn visits, to encourage tummy time, for example. I mentioned responsive feeding around breastfeeding. It's not just breastfeeding. A formula-fed baby or a bottle-fed baby, we can help parents to know the signs of a baby's signs of hunger and a baby's signs of fullness, and really being able to listen to them. We know that babies are born being very good at listening to their body's cues for hunger and fullness. And we found in studies that kids as young as the age of 3, really, and maybe even younger, have lost that ability. There's so many other reasons why we eat, or pressure to eat, that there's a lot of overeating, and then we aren't as good at being able to listen to our body's cues of hunger and fullness. So really intervening and mentioning that and helping parents with that early on can be hugely impactful. And then I mentioned already, breastfeeding, maintaining to exclusively 6 months ideally, and have that responsive feeding even with the bottle. And then solid foods and the introduction of solid foods. So we know that any solid foods that are introduced, babies who have had solid foods introduced to them before the age of 4 months are more likely to have childhood obesity later. So we want to really encourage parents to not do any complementary foods before 4 months. And really, most babies are probably ready for those closer to the 5 to 6 months. They're exclusively breastfed, waiting to 6 months. If they're not really using the baby's cues and readiness to determine when to introduce solids. And then the types of solids, having a lot of vegetables, and babies generally, as we know as pediatricians, they generally like most of the foods as they start and are developing, increasing intake of solids. So really trying to get some of the foods that toddlers tend to reject later in and familiar to a baby early on can help to decrease the likelihood they'll become picky to those later. And then responsive and authoritative parenting. So I talked a little bit about what responsive feeding means, listening to a baby's cues for hunger and fullness. Authoritative parenting is really in a line with an approach that some may be familiar with, that Alan Satter really came up with and works well, as this idea of division of responsibility, which especially as kids get older in the toddler years, we talk about more, but really the parent helping to set the stage of when food's offered and what's offered and where, trying to set structure for meal and snack times. And this is especially important as babies get older, which we'll talk about, but then letting the baby or the child decide, what they're going to eat and how much of it. Okay, and that's really especially impactful as the kids get older, and in the 6 to 12 months phase, as they're kind of getting into the second half of their first year of life, they're having more and more solid foods. And so they're really then learn more about self-feeding, really exposing them to a variety of tastes and textures early on. We know that the more familiar a child is with a taste and a texture later, the more likely that they're going to like it and they're going to accept it. So this is a really fantastic opportunity to expose kids when they're willing to try things to the bitter vegetables, to the spicy foods, to the fish, so that later on they'll be more likely to eat it and not refuse it as much. Having those routines kind of going along with that authoritative parenting approach that I mentioned. Really healthy beverages. So we want, ideally exclusively breast milk to 6 months and really continuing to 12 months or longer. Formula, if a baby's formula fed, having the formula, but nothing else except for those and the foods until 6 months. And then at 6 months, water can be introduced, but really nothing else, no juice. For no reason, really. I know constipation happens and some pediatricians recommend juice at that age, at that time, but really trying to avoid that because the sweet flavor, we're naturally born liking that. So trying to minimize that exposure early on. But water in an open cup can help also with that fine motor development. And some active play, limiting screen time or zero screen time ideally, really at this age. And then there's that impact of role modeling. I know there's some questions in the chat box. If it works okay for everyone, I'm going to continue because we're going to get into some of this a little bit more depth, and then we'll have those 15 minutes at the end, and we can really address the questions as they're coming up then as well. Okay. So we've talked about the newborn period, and then we've got our baby who's developing, and they started to be able to eat solid foods, and they're doing more self-feeding. And they're liking things for the most part early on. They're starting to cruise around now. They're going to be walking around that year. And when the year strikes in that toddler zone, usually a toddler is still pretty open to eating lots of fruits and vegetables. If we can get them the whole grains, we can get a really healthy, varied diet in kids at this age generally, because parents are generally pretty conscientious about it for their kids at this age. And at this age, kids are usually pretty open to it. We want to try to continue to recommend just with the formula can transition now to milk, or the breastfeeding can transition now to milk, and then water and nothing else. We want to really try to encourage no juice. That's probably the most impactful thing that we can do, honestly, because the sugary drinks are probably the biggest contributor to childhood obesity. Continuing with the activity and really focusing in on those gross motor skills and encouraging parents to give their kids lots of opportunities to practice them. Maybe less time in the stroller now and really more time as they're getting competent at walking and being able to be more engaged with the rest of the family as a toddler rather than when they were a baby. Continuing with some of these other, the authoritative parenting with that division of responsibility, and sleep. Sleep is critical throughout childhood, and we're learning more and more the role of sleep and quality sleep on risks for childhood obesity. And, we think of childhood obesity, we often, think nutrition, physical activity, but really, we should be thinking more broadly than that. In the Healthy Weight Clinic that I run, we really break it down into 5210, which was first described by Dr. Tori Rogers in Maine, who's on our executive committee for the section on obesity. But that's 5 vegetables and fruits a day, less than 2 hours of screen time. So thinking about fruits and vegetables, thinking about screen time. The 1 being an hour of physical activity, but really focusing on that physical activity. The 0 being sugary drinks, so we know the impact that has and minimizing that. And then I add sleep, so a focus on sleep routines, the quality of sleep, as well as the duration of sleep. And we call it social emotional wellness, the stress management. That's really kind of the mental health aspect to childhood obesity, and that's kind of where the relationships piece comes into, and that bonding for the first 1,000 days. So as we think about this, I just kind of went through our several key areas to think about with our pediatric patients when they come into us, the babies when they come in. And we see these kids all the time in the first 5 years, especially when they're babies. And then, beyond that, annually, they have 31 well checks in the first 21 years of their life, and 20 of those are in the first 5 years. So if we are having consistent messaging, especially if we're able to target it to that family and what they're struggling with or the challenges they have, or that child's growth and development, we really have a really great opportunity to make a difference. The work we do with childhood obesity can sometimes feel frustrating because we maybe feel like we're not making that big of a difference, but we are, and especially if we're able to prevent it. You may not know all the cases you prevented, but as you're monitoring at all of these well checks and discussing with parents at each of those and giving them opportunities to share their challenges and helping them troubleshoot, we're really making a big difference. In fact, parents, even though in the current day, we often feel like parents are not coming to us all the time for their information and they're getting it everywhere else, and we wish that they would, trust the evidence that we share with them, they do want to hear about this from us. 67% of parents, they most expected to find resources from us as pediatricians. So we need to feel really comfortable with this topic area, but we also need, that parents want this from us, and we're really well positioned to provide it. So this is, more to say, like, it's us. We are well positioned to be the ones to help families. So these next few slides kind of go into or kind of list out a little bit more of some of what I've already mentioned, but let's look at it again. And this is really just to help you with the bullets. You'll have the slides. So if you're thinking about, what should I be covering? These are some key areas. But if you kind of think of it in that terms of that 5210 sleep, social emotional wellness, 5210 SS, those are like the key, areas that we want to hit on. In fact, I would actually say 5210 SSS, because that last one is the schedule and the structure. Because we all know as pediatricians, one of the most impactful things that a parent can do in helping set their child up for success and also everybody's sanity is having structure and routines for that child, whereas a lot of consistency so kids know what to expect. The same thing goes with prevention and treatment of childhood obesity. Having a schedule and a structure and routine is really effective in helping to prevent and treat obesity and just overall everybody's well-being. So, what are we talking about? I just, went over all these things that we could be talking about, or maybe we should be talking about, although, time is of the essence and we have 1,000 other things we're doing too. So how do we fit it in? Well, we're doing a lot already. It's really encouraging to see that 92% of pediatricians are talking about juice and sugary drinks, because we do know that this is a hugely impactful area. You know, through the section on obesity at the AAP, we're the first authors of a statement with the AAP and the American Heart Association on policies to reduce sugary drink consumption in children and adolescents. And we targeted that because we know in the review of that study, or that paper, this is the most impactful thing we can be doing. So we're doing it fantastic. So now that we've got that covered, you know, what other things are we talking about or could we be talking about? We've got a lot of it underway. So kudos to us for what we're already covering. And then, you know, there's some things that are lower percentile on here that we're not addressing that are also very impactful, and they could be areas to target. For example, you know, I know you can see the slides, so you can kind of read through this, but, you know, 45% of us are addressing family meals. And you know, when I'm asked just generally, you know, like what's one thing, if you offered one thing to parents that they could be doing to set their kids up for a lot of success, what would it be? And my answer is to have family meals, and having family meals from very early on, because not only are children who eat meals with their family members as often as possible more likely to eat more fruits and vegetables and less likely to have childhood obesity, but they also tend to have better mental health, and they tend to get in less risk-taking behaviors when they're adolescents, and they tend to have a stronger relationship with their family just overall. So it's one thing that is part of a schedule that can be hugely impactful across lots of areas. So maybe we could be talking about family meals more, but listening to hunger cues, also critical. In fact, with my healthy weight clinic that I run, you know, with the older kids especially, we do a session on a hunger scale, which helps them to have a visual to think about, you know, how to identify when they're hungry and when they're full. And we eat for so many other reasons. Being aware of that can make a huge difference. And then, you know, food rewards is down here at 29%. Don't get me started on food rewards, because, you know, and this one's really hard to talk to parents about because it's such an effective strategy in the short term. I mean, how many times do we have patients coming in and they're getting their vaccines and the parents are saying, you know, okay, guess what? You know, as soon as this vaccine is done, we're going to get ice cream. So just get through this. And it works, and it helps the child to be less distressed. But it also creates an emotional association to that child of, you know, the food reward of the ice cream, and it can lead to emotional eating later and things like that. So, you know, it's something that we could be addressing more in a way that's empathic and understanding to parents, you know, why they're using that. I think probably many of us with children are probably guilty of that, and it's really hard to not do it, but it does have a negative effect. So that's kind of the overview of, you know, what we could be doing, what we're already doing, and then some hot topics that come up all the time that we get lots of questions about. So, you know, to share kind of what's the best evidence or the recommendations, at least at this point. So I mentioned, you know, really trying to encourage our parents to not do any complementary foods before 4 months for sure, because we know that that's really detrimental. That said, you know, 16% of our families are already doing that. And then about 38% are between 4 to less than 6 months, and then about a third are 6 to 7 months, which is fine. So with that, as I mentioned, the youngest kids who are starting complementary foods, they tend to have a pretty good diet. They're eating fruits, most of them are eating some vegetables, you know, they're getting a little grains, still 14% get sweets. We would prefer them not to have any sweets, but overall it's looking pretty good. And then they hit 18 to 24 months. And it's generally around that time that the neophobia, which is the fear of new foods, kind of kicks in. So we all know this, right? The picky eating in the toddler, it's classic, it's very common, it's normal development, we expect it. And when that happens, the vegetable intake tends to go down. You know, there are more grains, usually processed grains. We're trying to get more snacky stuff. The sweets, now we're 63% are having sweets. So the diet now is starting to get a little bit more concerning. But that said, we know that kids are getting a little picky at this point. So we don't want parents to be forcing them to eat vegetables, because that ends up backfiring. But this is where that division of responsibility that I mentioned where we really can encourage parents. You know, they're frustrated, they're coming to the office, like, he won't eat any vegetables, I can't get any greens in him, all he wants is dino nuggets and mac and cheese, I don't want him to starve, so I just give him that. Really stepping back and really encouraging this idea of the division of responsibility to the parent, like, okay, what you're experiencing is very common and it's a normal part of a child's development. How we react to it or respond to it can impact how long it lasts. So really, you know, as a parent, try to have structure. If you determine, you know, when meals and snacks happen, try to have them happen at the table and not kind of throughout the day. And then, you know, you decide what foods are offered, and then let the child decide of what you'd offer them, what they're going to eat and how much. But you decide what they get. And if they don't eat what you've given them, then they can eat again at the next scheduled meal or snack, and you can offer them food again, but don't cater to them and stress out too much. This applies to most all children. You know, of course, some kids have the severe form of this, or we're worried about their weight gain or their growth, or they have other, you know, they have food allergies or, you know, other conditions where we maybe approach it slightly differently. But otherwise, really encouraging parents to roll with the pickiness and not cater to it, and it won't last so long. But you can see, you know, kids have a super healthy eating food quality, dietary quality. 6 to 11 months goes down at 1, it's going down more at 2 to 3. That's the picky phase. If we approach that right, the picky phase doesn't have to last forever. So we could be getting those kids to have fruits and vegetables and accept them again. But even at 4, you know, their dietary quality is still not kind of going back to where it was when they were 1. So what can we do about that? So there's the food approach, the division of responsibility, the structure, you know, offering the vegetables and fruits frequently, encouraging parents to offer, even if they don't eat it, keep offering. Don't offer sugary drinks. Please keep juice out of the house, you know, make it easy to just do water and milk. And then really the physical activity and continuing to develop their motor skills. So they're going from the gross motor skills, the fundamentals of learning how to walk and learning how to run, to being able to coordinate that. They're learning how to jump, to throw, to catch, to start to play some sports in a fun way that's using their body, coordination. You know, gymnastics and tumbling is actually the most useful thing kids can be learning at this age, because it helps get them fundamental skills that can apply to lots of activities later on. But really encouraging the activity. And then, you know, the screen time is a struggle. We've kind of talked about that a little bit. So ideally, the screen time would be limited to less than 2 hours. So there's the amount of time. Other key things around screen time at this age that I talk about a lot, that come up a lot, is trying to not have the screen during meal times, because that takes away the mindfulness around food, and it can lead to mindless eating, which increases, you know, caloric intake that's unnecessary. Trying not to have the screen within an hour of going to bed, because we know that the backlighting on the screens makes it harder to fall asleep, so that can negatively impact sleep, and we've already discussed how important sleep is. And then with screen is trying to avoid exposure to ads. So that's through TV, but also now there's ads everywhere on apps and a lot of the things that, you know, YouTube for kids and stuff the kids are watching. And those ads tend to be for junk food, and they tend to be for sugary drinks, and it tends to make kids want them and beg for them, and parents give in, and then it sets a cycle. We know that other than, you know, the sugary drinks consumption, the marketing is a huge problem and a huge contributor to childhood obesity. So, you know, what can we do about this? There's so many things. Where do we start? How do we prioritize? So to do that, let's go back to what we're talking about and, you know, what we could be talking about. So here's that slide again. And so let's kind of talk a little bit more about some of those areas that we don't talk about as often. Again, this is kind of the early years. So we talked a little bit about the fruits and vegetables, the less sugar, move more, limit screen time, the patterns, family meals, and then that responsive feeding. Okay, so tailoring it. Well, how do we tailor it? So there's the areas that we talk about all the time that are part of our spiel that we have in our visit summaries, and it's the general guidance. And then there's the areas that some of us talk about, but not all the time. We don't just want to lecture parents, because that it's not really very well received and not really very effective. So what do we do? And then with that, so I should mention, there's the things we talk about, and then there's the way we talk about them, and then there's the underlying concern that we have in the focus of this talk. We're talking about preventing obesity, but what if you start to recognize that the child is developing obesity or has obesity? How do we talk about that without upsetting parents or being judgmental about it, unintentionally, of course. So we have to be thoughtful about it. So a couple of things. One, be careful about using obesity. It's a diagnosis, it's a real condition. It's unfortunately got a lot of stigma attached to it. So while medically we talk to each other, we know, BMI is greater than 95th percentile, it's obesity. When we're talking to parents, the word can make them feel a little bit offended or defensive. So I always talk about it in terms of the BMI percentile, and I show them the growth chart and I show them the lines. So for our system, the blue line is the 95th percentile. So I talk about, this is where we are, that we're above the blue line. The blue line, there's more above there, we have more health risks. So we're hoping to, not be above the blue line. So this is one piece, but more important than this piece and the growth chart is kind of the day-to-day habits and what's happening for you and at home and stuff like that. Like, what do you think? And kind of getting from them, what they think about this, and trying to connect it really to their reality right now and what's doable for them right now. In a really positive approach, saying, your child is obese and is going to get diabetes if you don't do something about this is not generally well received. So I would just avoid obesity language generally, but if you're going to use it, and this is just across the board, we want to say, a child with obesity rather than an obese child. So that's using person first language, which is really important to do. And if you're interested in kind of more on this with obesity, the AAP in the section on obesity, I think in 2017, we have a statement on, weight bias and how we can be less, we're not trying to be biased or we're not trying to be judgmental, but how we as pediatricians can better communicate with our families to help them and to help their children rather than to help them to be offended by us, with us having the best of intentions. And it's easier for parents to hear this and for them to listen to us and work together as a team and a partnership to help if we respect their expertise. They are experts on their child. We are just a part of the village to help them, but they are the experts. We explain the why and give really doable things. The juice conversation, is there doable? Would it be all right to try as an experiment? I always put things in terms of experiments because they, for a couple of weeks, it feels less final. It feels like it's okay to try. Could we experiment with not having the juice and see how that goes? Could we experiment with, trying to offer a fruit rather than a processed snack at snack time and see what happens, stuff like that. And acknowledging that it can be challenging and we're all in this together. So these are just some other examples of ways that we can talk about this with families based on the survey that the AAP did with parents and them telling us as the experts on their life and their kids of what works for them. And you'll have access to these slides so you can kind of look at some of these examples to practice with. So here's just kind of explaining why. So it's not just because I said so, it's clear statements and simple benefits right now. So, if your baby's breastfed, you're less likely to have ear infections, less sick visits, you don't have to see me as much, that kind of thing. So these are just some examples with screen time and, skipping the ads, as I kind of mentioned already. And just kind of to wrap that piece, it's, strive to really listen, of course we do, and then think about the way that we say things so that it's likely to be well received and then really tailored to that family. And if you're interested in that more and practicing that, motivational interviewing is a great skill to develop and to use. It's very effective. And the AAP does have a resource of an app that's called Change Talk, where it gives the example of a family with a child that has obesity, and you can go through and pick kind of what you would say, and then it can help you to see how close that is to motivational interviewing approach and give you some tips going through that. So it's a way to practice with the simulation. And that's a wrap. That's the kind of the package of some tips and strategies to think about in the first 5 years. But I went through that fairly quickly, and I know it's a lot. So I think this would be a great pause to kind of get to some of the questions and kind of explore this together a little bit more.
Thank you so much. That was great and worth waiting for. We were expecting to see it in the spring, and we're glad you could join us in the fall. If anyone wants to start their video and unmute, you're welcome to ask a question, or you can put a question in the chat. I will say that early on, my child, in addition to the vaccines, needed a lot of dental work. So we always bribed him with Legos, which turned into a very expensive but lovely habit. And now you can see that Stranger Things right behind me, the upside down. That was our last summer vacation, was putting that together. So I've made a real investment in the Lego Corporation at this point.
Yeah, but that's a great example too, though, of using the approach of, if we were to talk about food rewards in a visit, and a parent's like, but I need them to, get their shots. What are non-food rewards? Like, Legos may be a very expensive one, but it's great for fine motor development and kids love it. Maybe it's sticker, what motivates that child that's not food and that's little, and trying to do that instead. So thank you for mentioning that example. It's a great one.
Yeah, it was sitting behind me. I was like, oh, I've got to mention that.
It's perfect.
So we do have some questions here in the chat. Are babies fed breast milk with a bottle less able to self-regulate their feeding the babies fed breast milk directly from the breast?
Yeah. Not necessarily, but potentially. And that kind of gets at, it depends on the approach of a parent to some extent on that responsive feeding. So if the breast milk is being given by a bottle and a parent is counting how many ounces that baby gets with every feed, and if the baby doesn't get the 4 ounces, only took 3, but is kind of turning away and isn't interested, but the parent's like, look, they're supposed to get 4 ounces and keeps pushing them to finish it, then that can be detrimental and kind of similar to what can happen with bottle feeding with formula. But both with formula and breast milk, if a parent's being very practicing that responsive feeding where they're listening to the baby's cues of hunger and fullness, and they're stopping when the baby's full, and that, then it doesn't necessarily pose a problem at all.
Great, thank you. Anyone else wants to turn on their video or put a question into the chat? I will remind you, I think most of you have by now, but make sure at some point during today you put your full name into the chat so you signed into our virtual conference, and I know that you're here, and we will be sending out the recordings from today and information on how to claim the CME. But I'm not seeing any other questions, so I think that is great. Oh, no, Dr. Greenspan's coming online.
I have one quick question. I have a few families that consider babies that are, they say a fat baby is a healthy baby, and it may just be a family belief, a cultural belief, but I wanted to see how you can address that.
Yeah, that's very, very common for us to see. And it can be tricky too, because some baby, especially like breastfed babies, can be all over on the growth chart, and sometimes they can have a weight for length that's higher than 95th percentile but levels out later. But I think it helps if we look at the growth chart and with those visits and that conversation, and looking at the weight for length for the baby, and if it's above the 95th percentile, sharing that with the family and saying that we've learned that rapid weight gain in the first year and being at a higher weight for length for a baby does increase the risk quite a lot for a child later on of having to, having childhood obesity or having struggles with their weight. So it's something that we want to kind of be aware of. And then kind of transitioning it to the conversation of around some of these actionable steps. So that 5210, SSS that I mentioned, but just like the habits, and see like, what are the habits like? Because are they trying to feed the baby to fatten them up? Or is it actually, the baby's not doing juice and the baby's breastfed and is eating fruits and vegetables and they have really healthy habits and sleeping well and everything else? And it's like, okay, then we'll just kind of keep an eye on it.
And we have one more question from Dr. Halm asking how she can help a family to understand the importance of a healthy BMI and a healthy diet when the whole family is overweight.
Yeah. So a couple of pieces to that. So not necessarily for this example, but because if a child has, overweight or has obesity and their family members do too, it doesn't necessarily mean that they don't care or it's not important to them or they don't have healthy habits. And in fact, a lot of times they are very aware of the concern, and there may be family members with type 2 diabetes and things like that. So I always like to talk about it in terms of the health habits in that situation. So you're talking about the growth chart, showing them the BMI percentile, explaining that above the 95th, we get concerned about health risks. But most importantly, it's the day-to-day, how things are going with the nutrition and the activity and the sleep, how's the family meal, stuff like that. So you can really focus on positive approach and the healthy habits that ultimately are going to impact that BMI percentile quite a lot. And it can feel less, parents can be a little less defensive if we kind of go back to kind of talking about, as we do for all kids, those healthy habits rather than overly focusing on the weight.
That's great. That's great. All right. Well, I'm not seeing anything else in the chat. So again, on behalf of everyone who's virtually on, thank you very